Good morning. Thank you very much, Dr. Lopez-Ibor. I am very lucky to work with your team, with Santi and Mano. We are making a very good job here in the hospital. And I'm trying to speak for something different, that means that the majority of the people here are endovascular neuroradiologists, but I think that there are a few neurosurgeons here. And I'm speaking about what I called sometime in the international meeting of endovascular, the third way of treating of AVMs, and in this case, deep AVMs. What we see in this session, we see that many people are speaking about the option of embolization of deep AVM. But in the majority of the publication until now, this is one way to help the surgery and the radiosurgery. Well, let's go on. What we are calling the deep AVMs. How can I go forward? Here? Sí, pero. Okay. Okay. We call, in the group of the deep AVM, I take all together the brainstem AVM, basal ganglia AVM, and thalamic AVMs. And there are no so less frequency AVMs. We think that in the majority of the cases, we have for 3 to 30%, which we call deep AVM, but if we gather all together with brainstem, we have more patients, around 20% of all AVM. The characteristic of this AVM are that they have probably more morbidity and mortality because they have more percentage of bleeding and rebleeding. Don't forget two phenomena, bleeding, first bleeding, and rebleeding after the treatment. And the third problem is that they are localized in very important area of the brain. It means that small hemorrhage can produce a high morbidity. And which is the majority of these deep AVM present debut with hemorrhage. This is the first diagnosis of these AVMs. Therefore, we have the progressive neurological deficit. The epilepsy is very rare in this case because there are no epileptogenic area. And which is very important is that if we compare the deep AVM with the general AVMs, the frequency of the hemorrhage is so high, 50% annual hemorrhage in the deep AVM. If we compare with the general AVM of the brain, that the annual frequency of the hemorrhage is from 2 to 4%. But not only the first hemorrhage, the second hemorrhage, and we have the accumulated blended frequency around 60% in 10 years. What does it mean? That we are forced to treat this pathology because they have high morbidity and in this some case high mortality. And the way to treat of this patient, I think the most classic is the surgery. Therefore, we are going through to embolization. Recently, we are making a lot of radiosurgery, but which is the basic concept in my point of view is the combined treatments. The combine of all these arms that we have in our hands to treat this kind of pathology. I gather all together the most important publication about the surgery of the deep AVM. What you can see here is that we have from the mortality, very important, from 0 to 26%, very high mortality. We have the resection from 25 to 100%. It means that it depended to the many publications, many authors, many plays that are making that we have high mortality, but in some cases we have also high result of the problem. We are speaking about the embolization. I make check in PubMed of all the publication, most important publication about the embolization in the last 20 years. This is one in 1993 that they planned the very nice idea that the embolization of the deep AVM lets us, they are using the embolization to help in the surgery or in the radiosurgery. In this publication, for the first time, they explained that the embolization can produce some pathology or ischemia of the brain. This is another one in 2003, a very important publication, and what I'm learning the conclusion, the endovascular management of the brainstem AVM may be an alternative to treatments such as radiosurgery and microsurgery in selected cases. It may be not as risky as previous true. Embolization can reduce the size of the AVM and possibly make it more treatable by radiosurgery and surgery. This is the concept that I like to introduce in this meeting. And the last, that the doctor mentioned it in the first communication of this part, is published in Journal of Neurosurgery 2016, and they speak about the ischemic complication of the embolization. And in this publication, they explain also that the embolization can help us to make surgery and radiosurgery. What it does mean? I want to tell that it's true that embolization can help us, but we cannot resolve all the problem with the embolization. And we have another way of the treatment, and this is the third way that I mentioned. I defended it in the international meeting, and I am defending it here, that we have another way to treat. We have not only embolization, we have not only surgery, but we have another way. That is a very nice one, that is radiosurgery. Which is radiosurgery? Radiosurgery is a minimally invasive technique, is a safe procedure, is effective procedure, and is gathered all together in the concept of combined treatment. Don't forget it, combined treatment. Not only surgery, not only embolization, not only radiosurgery, but all together to help our patients. But which is in the base of radiosurgery is the radiobiology of the radiosurgery. What can we produce with radiosurgery? We can produce step by step the obliteration of the artery that are going to the AVM. It's strange because radiosurgery have two effects. In malignant, in the tumor, we have necrotic, we produce necrosis. But in the artery, we did not produce necrosis, but we are producing the proliferation of the of the muscle that is around of the artery. This progressive expansion of the intima, including proliferation of smooth muscle cell, can produce the occlusion of the artery. The question we plan in the radiosurgery, and many people that make radiosurgery know it, is true that more doses, better result? I did not agree. Why? Because the process of the obliteration began at 12 gray. This is radiobiological confirmation. This means that more than 12 grays, we can have good result. We cannot go up to 25, 24, 26 gray. No, it's not necessary. With some middle dose, we can have very, very good result. And this is very very nice demonstration what's happened with the artery in the beginning and after radiosurgery. You can see here. This is the obliteration of the artery after radiosurgery in the time from 1 to 3 years. This is the problem. The time from 1 to 3 years. In this time, maybe we can have hemorrhage, but it's demonstrated the frequency of hemorrhage is the same that if we did not treat the patient. Well, in the classification of AVMs, we have two very important score scale. Spencer-Martin. Spencer-Martin is a score scale that speak about is maybe more the surgical scale of the evaluation of the patient. We don't have it, we don't need this if we are speaking about the AVM. There is now Paulo Flickinger score. It means that it's more complicated one. There are some new elements as the volume, patient age, and AVM localization. But what I think, if we decide to treat with radiosurgery AVM, we have a major indication and minor. The most important are the volume of the AVM, the localization, and the presence of intranodal aneurysm, because it's very important before, if we can, to treat the AVM or radiosurgery, maybe you have to make the embolization. And minor elements are two: arterial flow and size of the artery. If we base in this concept, we think that, for example, the embolization will help us to have low flow in the artery, and maybe we can obliterate some big vessel in the combined treatment. We have Dr. Luis Lorenzana make a very interesting study in our group about the radiosurgery of brainstem AVMs. And we have a very high number of the patients, 41. In no publication there is very important group of the patient. And we make around 16 radiosurgical procedures in the treatment of this patient. 9 of these patients done embolization, previous embolization, it means 22% in 12 procedures. And the surgery, they tried to make the surgery, but it was not the surgery of the AVM. In the majority of the cases, it was the surgery of hydrocephalus and hemorrhage, intraventricular hemorrhage in 32% of the cases. The distribution of the AVMs in the brainstem are in the upper part, 72%, and therefore they're in middle part, and this is the distribution, upper, middle, and in the lower part of the brainstem. And in majority of the cases, we have hemorrhage. And very important are in the low part of the brainstem. If we classify it with the Paulo Flickinger scale, we think that this is what we have in the classification of the patient. In the 22 patients, we make only one treatment. In 40 patients, we make 2 treatments. And in 2 patients, we make 3 treatments without toxicity. We are speaking about the brainstem patient that they have any solution. This is a very nice case. It's small AVM, mesencephalous AVM, we made radiosurgery, and you can see on the right part of the slide that the AVM is quite embolized. And those are the results, our result in the treatment. We have 16% of the rate of the occlusion of the AVM, very high. If we compare with the embolization procedure, and we have not possibility to make surgery procedures. And the mortality, and we have only 8%. Only 3 patients, they make hemorrhage after the radiosurgery. And if we're speaking about the deficit, neurological deficit, we have only 1 with permanent neurological deficit after the radiosurgery. It means that we have low morbidity, very low morbidity, and we have very low mortality. There is another case that with brainstem AVM, we make a radiosurgery. This is the study of angiography and MRI. And those is the next MRI 48 after the radiosurgery, and we can see here that we have a complete obliteration of the AVM. It's another case, very interesting case, that was impossible to make. The surgery was impossible. It is impossible to make embolization. They tried to do it, but was very difficult. We make radiosurgery, and we can see here the angiography 12 months later. It means only 1 year. I speak before that we can, maybe the procedure of the occlusion and radiosurgery is from 1 to 3 years. 1 year later, we have the complete occlusion of the AVM. But there are very something interesting cases. A big AVM with hemorrhage in the low part of the brain stem. How can we treat? We can try to make embolization. They try to do it, but was impossible. Can we make surgery? I think that is very difficult to make that surgery. So we make radiosurgery, and this is MRI. Many years later, we can see that we have only small residual part of the brain, of the bulb that is irradiated with irradiation. This is very interesting case. A new guy, a new child with this big AVM. What to do? We send it to make embolization. They tried to do it, but it was very difficult. And we decided to make radiosurgery. But using some technique of the cyber knife, we can not only irradiate the AVM, but we can protect the vein. There is a big problem in the hemorrhage after radiosurgery that we can produce sometimes the necrosis of the vein. But making radiosurgery, as you can see here, we can irradiate all the AVM, but the big vein, drainage vein, we can make as the organ at risk which is in the system plane of radiosurgery. It means that we can treat the AVM, we can treat the arterial nidus, but we can protect the vein. And this is a very interesting technique that we can do with cyber knife. This is MRI before, and this is MRI after radiosurgery. You can see that this big AVM is quite occluded by radiosurgery. This is a very interesting case, a young lady that made embolization, that tried to make surgery, but they did not accept to make surgery. They tried to make embolization, but they couldn't embolize this because there is a deep and big AVM. What to do? The patient presented a hemorrhage. She is a hemiparetic and with a more headache. And I think that after they try everything, the patient came to us and asked me that, what can I do for her? And I decided to make radiosurgery. Very big AVM, deep AVM, in very difficult cases to treat. And I decided to make two-stage radiosurgery. I treat one part in the first treatment, the lower part. 1 year later, I treat the upper part, that is the concept of stage radiosurgery. And now, this is the second treatment with the same dose of the treatment. I combine the two treatment, and now you can see 26 months later, after the first radiosurgery, the AVM is quite occluded. They make a very small part of the AVM. I make a third radiosurgery here, and the AVM was totally occluded without hemorrhage. This is another patient with internal right capsula AVM, and we make radiosurgery. And this is the angiography after the 21 months of radiosurgery with complete occlusion of AVM. There is another case of thalamic that we sent to make embolization. They didn't do it. Their surgery was impossible, and we make two radiosurgery. First one, after 3 years to make the second one, and you can see in the end, in this, the 27 months after the second radiosurgery, we have the complete obliteration of the AVM. Those are all the results of our series. In the majority of the series, we use the MRI. Therefore, we decide that the best way to decide that if the AVM is occluded is angiography. For this reason, in the majority of the case, we decide that the occlusion is only when in the angiography there is no nidus. And this is the Kaplan-Meier rate of liberation about the radiosurgery. More than 60% of the patients are obliterated. And we have only 8 patients with hemorrhage after the radiosurgery. From these patients, 3 of them died because was the brainstem patient with very high morbidity. And those are the list of the patients that they make hemorrhage after the radiosurgery, and we analyze one by one. And this is the Kaplan-Meier survival number of the patient. 92% of the patient, they survive after radiosurgery without problem and without neurological deficit. And if we compare our seria with all that have been published, we can see that maybe we are a little bit superior of the seria published until now, and the result of the radiosurgery in the deep AVMs and in the brainstem AVM can be compared with the patient with embolization or surgery. I think that we have a little bit more advantage because we have more percentage of occlusion with radiosurgery. Generally, I think that the conclusion are that the neurosurgery and embolization in deep and brainstem AVM are not recommended as a first or as a first choice treatment of the patient. The risk of hemorrhage is high in the supratentorial hemispheric AVM, both in the acute involution and high morbidity and mortality. Radiosurgery is an effective and safe treatment with 60% of AVM occlusion and low morbidity, around 10% of the patient. Polo-Flickinger score can help us to predict the radiosurgery treatment result in a relationship with a patient with AVM characteristic and specific. It's not necessary high dose of the irradiation. The proliferative process begins in 12 grays. It's very important to understand it because more dose, more toxicity, more necrosis. But we have to understand that the proliferative process begins at 12 grays. It means that it's not necessary to have high dose. Second treatment can be held in the case of failure. We have some patient that we may second, and we have 2 patients that we made third treatment without toxicity. Radiosurgery, in my point of view, has become the first choice treatment in the deep and brainstem AVM. Thank you very much.
Questions?
Thank you, Dr. Sallabanda, for your presentation and revision of your experience. I think the deep AVM is very complex to treat it. I agree with you. The radiosurgery is mandatory to treat it. The AVM in the deep part, in the deep brain, but this indication for me is more limited. Why? Because the deep AVM are bleeding more than other AVM. Why is bleeding this deep AVM? Because every patient, every deep AVM have an intranidal aneurysm. Maybe you don't see in the initial angio or initial MR the intranidal aneurysm because you are many vessels and it's impossible to see you are the intranidal. But the clinical evolution is the bleeding, and this bleeding normally is bleeding in the ventricle, is not bleeding in the parenchyma. But why? Because it's the collateral anatomical circulation. And I agree with you, it's very difficult to treat it, but it's mandatory to treat it, of course, of the combined. For me, the combined is embolization and radiosurgery, and surgery is depending on the quality of the neurosurgeon. It's not easy to surgery of the deep AVM in thalamus or lenticulostrial territory. But finally the change of the effect of radiotherapy in the brain, or effect of the radiosurgery in the brain, you see in your presentation, is the obliteration of the vessel and hypertrophia of the vasovasorum around the vessel. And this, the two cases present before, you are the modification of the vessel, and this is very, very complex situation to treat it with embolization or treat it with surgery or radiosurgery. My question is, one story of bleeding of the deep AVM. Your first choice is radiosurgery, or your first choice is analyze with angiography and embolization and decrease the pressure, or it's not, you don't need the embolization?
Well, good question. Difficult one, good question. I think that, first of all, if we are speaking about the aneurysm, intraneedral aneurysm, I told you that the intraneedral aneurysm, there is a problem. But it's a problem for deep AVM, the same problem of the parietal AVM, temporal AVM, it means that this is a problem. If we have an intraneedral aneurysm, I propose that it's possible to make the embolization of aneurysm. This is first one. Secondly, it's true that what you present in what's happened after the cobalt radiotherapy, but we are not speaking about cobalt radiotherapy. We are speaking about radiosurgery. Radiotherapy and radiosurgery are two different concepts. It means that radiosurgery is one dose, and radiotherapy is a fractionated dose. It means that it's very different, one and the second one. And the cobalt treatment is, I think that is another time, another period with some kind of result. But answering your direct question, I think that it's not one person decision. It means that we can make this decision in a group. In this group, we can have endovascular, the surgeon, and a radiosurgeon. And we can decide what the best is for the patient. I did not agree that in some center that there are very good neurosurgeons that can make radiosurgery, or there are very good endovascular, neurological endovascular, they make embolization, and everybody have to make what they like to do, what they know to do. I think that we can speak with which is the best for the patient. Which is the best for the patient? Maybe in some case we have to make embolization before and radiosurgery after. Maybe in some cases we have to make radiosurgery before and embolization after. It means that we have to speak about combined treatment. But what is published until now, to make a checking of all the publication in the last 20 years, is that the radiosurgery at the first choice treatment is superior of embolization in the control, in the AVM occlusion, and in the morbidity of the patient. It's meant we cannot make the decision, I think radiosurgery, no. Maybe it's combined treatment, and the decision you have to make in the committee. But now I think that radiosurgery is safe treatment in maybe the first choice treatment.
Another question: in your series of experience, you are case of radioedema or radionecrosis, because when I started radiosurgery to treat it in 75, Steiner talk is the first experience is to treat the patient with a psychiatric patient to leucotomy with radiosurgery, and have too many complications to radioedema, radionecrosis, and then is evolution to the treatment of the AVM. In our experience of my patient, I have some case, not too many, some case, have a radioedema or radionecrosis is most frequently in the deep territory or the cortical territory. You are the same?
Well, I think that for this reason I explained to you that in many centers in the world, normally in gamma knife center, we go to high dose of irradiation because the way of treatment are 24 grays, for example, 24 grays. And in this case, you can have radionecrosis or edema. Yes, but what we are doing, that we know the radiobiology of the actuation or radiosurgery means that we can begin to 12 grade. 12 grade and up, we have to have effect. It means that it's not necessary to go 24 grade. We can go to 60, to 40, to 80, no more. And we have less radionecrosis. No radionecrosis we see in our series of brainstem AVM, 0. Well, thank you very much.
I would like to ask another question. What do you think, about treatment with radiosurgery of brainstem cavernoma?
Well, very interesting. Cavernoma is another pathology.
I know,
completely.
I know, but okay.
También el doctor Matsumoto.
Yes.
So this was a great presentation. The real issue is here that I've heard many speakers talk about the various techniques, selected cases, as you have also said so. The question is, when as Dr. Lopez pointed out, do you have a comparative case series comparing the various techniques in these things? Because all I've seen so far is people demonstrating their own techniques in selected cases. So I don't know which is the best technique, what really, because I'm speaking from a person who does not do intervention, or does not do radiation, does not do any of these techniques. So ma'am, I'm asking you, is there data that shows that radiation is better than embolization, or that is better than are you really saying that in a case series, or are you actually saying this as an epidemiological statement?
I don't understand the question. Which is the question?
The question is that, for anything, for any technique or any kind of procedure to be shown as to be the best procedure for a particular intervention, there should be a comparative analysis of all of the techniques. So, for example, embolization, radiation, surgery. Is there a comparative analysis of all three in a large study? And that's what will actually show what is better and what is not.
I think that we are speaking in the large study that is not so clear which is the best procedure. It's meant that is embolization, radiosurgery, or surgery. I think that, but if we compare the result, we see that the embolization in the publication, the occlusion in someone are from 26 to 100%, but in the majority of the case around 40%, the occlusion. If we are speaking about the radiosurgery, the occlusion is around 60%. It means that if we compare, it means that the best result of radiosurgery or with embolization. On the other hand, we have ischemia after the embolization. In the radiosurgery, we have not ischemia after embolization. We have been only 4 in our series of the patient, 4 patients with the transitory neurological deficit, only 1. It means it's very low, only 1. As permanent deficit, neurological deficit. It means that there are different areas, different opinion. I don't think that my opinion is the right one. I presented my opinion, and everybody have to make what they can do, what is possible to do with patient. I think that.
Right, I mean, I can understand. Just to give you an example of the unruptured aneurysm study followed, which said that, it's fine, 7 millimeter aneurysm should be ignored, 1 centimeter aneurysm should be ignored. Even if they go beyond that, then, of course, there's a big, then came Aruba and so on and so forth. And then now people are going after 3 millimeter aneurysms, 5 millimeter aneurysms in the ACOM territory, in the PCOM territory, because they've been shown to rupture at much earlier stages. So, but that's based on a large series of cases that have been compared across the board. So that's what I'm trying to get to. I mean, if there's a series, I would love to see that series presented here today at some point.
Okay.
Thank you.
Thank you.
There's another.
Dr. Kita, thank you for your citation of our paper, which was published last year. We support your opinion that your surgery is definitive solution treatment for brainstem AVM. And we believe embolization for brainstem AVMs can be an appropriate treatment option to prevent rebleeding combined radiosurgery. In our group, prospective study about radiosurgery followed endovascular embolization is going on.
Okay.